Hi, in this lecture I'm going to discuss why we would check the magnesium. Quite commonly in a ward-based situation, you're going to find yourself managing electrolytic disturbances in patients. Quite frequently, this will be the potassium. It may also be the sodium or the calcium. However, less frequently checked and of critical importance in many circumstances is the magnesium. Just as a brief disclaimer, this is aimed at medical students as well as practicing clinicians in hospital-based environments. As always, if you think you have a medical problem, I would advise that you seek your primary care physician. As a final disclaimer, I'm not an internal medicine specialist. I'm currently a doctor practicing in a pre-specialization position. Now, for a brief overview of disorders of magnesium, while they can occur in isolation, quite frequently they co-occur, especially with lower potassium. In fact, 50% of cases of hypokalaemia are associated with hypomagnesemia, and the reason for this we'll go into a little bit later. Just to define the cutoff for magnesium, you would expect greater than 0.7 millimoles per litre in the serum. With severe deficiency, it may go less than 0.4 millimoles per litre, and in this case, the magnesium will need to be replaced intravenously, and therefore the patient will need admission to the hospital. And I should also add that in primary care settings, disorders of magnesium are quite frequently underdiagnosed and may present with quite subtle clinical symptomatology. Where is magnesium located in the body? Now, most of it is split between the bone as well as the intracellular space. Very small amounts, in fact, are located in the serum, less than 1%, and therefore it's always important to bear in mind the very large reserve of magnesium present throughout the body that may not be reflected necessarily in the serum levels. In terms of what it does, it's quite commonly a cofactor for various enzymatic reactions and processes, and it's intrinsically involved in the regulation of a number of ion channels. So, how does magnesium play into the regulation of other electrolytes in the blood? Magnesium, as I mentioned earlier, is heavily involved in the regulation of calcium. Normally, calcium is under control of parathyroid hormone, which is secreted from the parathyroids in response to low serum calcium, and that's responsible for liberating calcium as well as phosphate from the bone. It also has an effect on the regulation of magnesium, which, as you recall, has a very large reservoir in the bone itself. So, low levels of magnesium in the serum actually increase parathyroid hormone secretion and therefore would raise the calcium. However, at very low levels, there's a paradoxical block. Therefore, when magnesium is very low, parathyroid hormone secretion is reduced, and therefore there's less calcium liberated from the bone, which will reduce the serum calcium, leading to hypocalcaemia. And you'll see a patient with hypocalcaemia, you'll do everything you can to try and correct that, but it just won't fix itself. And a very large reason for this might be that it's being driven by hypomagnesemia. Therefore, in hypocalcaemia, always have a look at the magnesium. Magnesium also has a major role in the regulation of potassium, and as I did mention briefly, 50% of patients presenting with hypokalaemia will also have hypomagnesemia. Now, as you may recall from physiology, potassium is absorbed in the proximal nephron, and then it's secreted in the distal nephron and the collecting ducts. And this is the way in which the level of potassium in the body is regulated by the kidneys. Now, why does magnesium affect the potassium in this way? Now, the channels that are responsible for what I just mentioned regarding the absorption and secretion of potassium are called ROMK channels. Magnesium actually has an inhibitory effect on this particular channel. And therefore, when magnesium is low, there's increased activity of this channel, leading to increased secretion of potassium in the distal nephron and collecting ducts, leading to a depletion of potassium through the urine. And in this case, once again, you can have a patient, low potassium, you give them intravenous potassium replacement, but it's just not coming up. And the reason might be because the magnesium is low. So, how would you recognize hypomagnesemia clinically? There are several ways in which you can do this, and it should be noted that most of them are actually manifestations of the secondary electrolytic derangement as mentioned previously. You may recall that calcium has a key role in regulating and stabilizing membrane potentials, and therefore has an important role in cellular signaling and nerve conduction, etc. And for this reason, there's an increased instance of tremor, muscle weakness, and fasciculations in patients who have hypomagnesemia. You can also get palpitations, and this may be secondary to arrhythmias caused by hypocalcaemia, as well as secondary to arrhythmias caused by hypokalaemia. There's also a reduced seizure threshold, and therefore these patients may present in some cases with seizures. And these cardiac arrhythmias, and to a lesser extent the seizure risk, are partly why it's so important to make sure that you do correct magnesium deficiencies, especially in severe cases in the hospital. In terms of the signs, there are two signs, the Trousseau and the Trousseau signs, and both of these are manifestations of the hypocalcaemia. How do these signs manifest themselves? Well, Trousseau's sign, this is listed by occluding the brachial artery by inflating a blood pressure cuff 20 mmHg over the systolic blood pressure. What you'd expect to see in the case of patients with hypocalcaemia after several minutes of this will be that they develop a wrist flexion with MCP flexion and extension at the interphalangeal joints and adduction, a deduction, at the phalanges. The second sign is the Trousseau sign. In this sign, the examiner will tap over the angle of the jaw just anteriorly to the ear, which is in the distribution of the facial nerve. Due to the low calcium and due to the reduced effects of the membrane stabilizing effects of the calcium, they will be essentially hyperexcitable, and what you'll get is very strong facial contractions. Looking for the literature, the Trousseau sign is somewhat more sensitive than the Trousseau sign. Now, what causes hypomagnesemia? There are several potential causes. The first route of loss would be the intestinal one. Now, this can occur through malabsorption, such as in the case of inflammatory bowel disease, particularly Crohn's, as magnesium is absorbed in the ileum and jejunum. It could also be lost in patients who've had some bowel resection, particularly of the small bowel. Magnesium can also be reduced in patients with diarrhea, much as it can be with potassium. Other common causes include drugs, proton pump inhibitors like omeprazole, lansoprazole, etc., quite common causes, and this is moderated by the reduced absorption of magnesium secondary to inhibition of the TRP M6 and M7 channels, which are located in the gut and play a key role in the absorption of magnesium. Other common causes include loop diuretics and thiazide, which induce renal losses, and for similar reasons, many instances of renal disease, especially tubular disease, can cause low magnesium in and of themselves. Finally, dietary causes can also contribute or cause hypomagnesemia. This may be in the case of just simply not having enough magnesium in the diet, and I'll go into this a little bit later. Hypomagnesemia also occurs in alcoholics due to reduced dietary intake secondary to self-neglect, as well as increased renal wasting of magnesium. And finally, it's important to always remember refeeding syndrome. Just to explain refeeding syndrome very briefly, refeeding occurs when patients have been essentially deprived of food for a substantial amount of time. It might be in patients who have been meal by mouth and are now resuming a normal diet. In this case, they have quite massive and dramatic spikes in insulin secondary to food intake, and this actually drives a number of ions intracellularly, including magnesium, therefore lowering the magnesium in the serum. Therefore, in patients like this, it's very responsible to always keep monitoring their magnesium, as well as their phosphate and other electrolytes like potassium. So, what would you do if you suspect a patient has low magnesium? Well, the first and the most obvious one would be to check their magnesium. However, you'd also make sure that you check their urea and electrolytes, and you'd also want to make sure that you don't miss a bone profile, so that would be the calcium and the phosphate as well. Secondly, it's always good to get an ECG. It's cheap, and it may reveal an arrhythmia. In particular, what you'll be looking for is changes consistent with, say, hypokalaemia, such as flattened T waves. It may also be, in some cases, a prolonged QT, as well as evidence of other arrhythmias secondary to low calcium and low potassium. In order to distinguish a route of loss for magnesium in a patient with diarrhea, obviously you would expect an intestinal route of loss. However, if you want to rule out a renal cause, then in addition to just assessing the kidneys and performing ultrasound and looking more closely at the urea and creatinine, another investigation that you can always consider would be a 24-hour urinary magnesium. Now, the reason you do this is to establish a renal cause of hypomagnesemia. So as you recall, low magnesium causes increased activity of the ROMK. Therefore, you would have increased magnesium in the urine, and that would be detectable on a 24-hour urinary magnesium. Now, all that's said and done, you've established the patient has hypomagnesemia. How are you going to fix it? Well, there are a few things you can do. Number one, make sure you hold any contributing drugs, always a good basic first step. So consider stopping any proton pump inhibitors, as well as loop diuretics. Secondly, you want to replace the magnesium. Quite obvious, but it's worth considering that there are oral routes as well as IV routes. The oral routes are actually quite well tolerated, except for osmotic diarrhea that can occur secondary to administration, and that may in some regards contribute to any underlying diarrhea that they may have if they have a gastrointestinal cause for their hypomagnesemia, such as IBD. Therefore, in that case, you'd want to consider IV replacement instead. Furthermore, in severe deficiency, you're going to want to give IV replacement just to get on top of that as quickly as possible, given the risk of cardiac arrest in these patients. As with the management of any other electrolytic disturbance, you're going to want to get regular blood tests. In the case of severe deficiencies, that's going to be daily. In the case of emergencies, you're going to want to administer some magnesium as well as correct any other underlying electrolytic imbalances. Of course, what you need to do as well is make sure that you keep rechecking these electrolytes post-infusion, make sure that everything's going in the right direction, and the more severe the deficiency, the more frequently you're going to want to check. But once all of that is dealt with, you need to make sure that you emphasize dietary replacement, try and replace any deficiencies, especially in the case of patients who have come in with a strong dietary component to their presentation. And looking just through the papers, it seems that the most magnesium-rich foods include dark leafy greens, examples being spinach, nuts, whole grains, as well as white potatoes. And I will just add, just as a basic note, in terms of intravenous replacement, the recommendation in urgent management would be to give 1 to 2 grams of magnesium sulfate over an hour. For non-emergency causes, it would be best to generally give around 4 to 8 grams of magnesium sulfate over approximately 24-hour period. So, what are the take-home points of this? Well, firstly, always worth bearing in mind, magnesium disorders are very frequently underdiagnosed, especially in the primary care setting. If you have patients presenting with hypocalcaemia or hypokalaemia, you have to bear in mind the very strong association with magnesium depletion, especially in the case of hypokalaemia. And if you have a patient who has an electrolytic disturbance and it's just not coming up for some reason, think magnesium. Finally, make sure as always you investigate for any underlying cause of deficiency. It's not just a matter of making the numbers pretty, you have to treat the cause. I provided some references if you wish to check my points or if you wish to learn a little bit more, especially about the regulation of potassium via ROMK, as well as the role of magnesium in the functioning of the calcium sensing receptor in the parathyroid. Once again, thank you very much. I hope you learned something from this. If you have any questions or queries, then please feel free to ask them and I'll try my very best. But please bear in mind, I can't provide medical advice over the internet. This is mainly meant for learning purposes. Thank you.